So again, I'm Billy Caputo. I'm going to be talking today about damage control resuscitation. And I am the ARD from Staten Island University Hospital. So when I asked you to speak in this, I'm proudly representing Staten Island, which is the most underappreciated borough. Some would consider the forgotten borough. So we're going to talk about damage control resuscitation. And the definition of this is how we optimally manage a traumatic hemorrhaging patient. And today I'm going to talk about 7 principles of damage control resuscitation that's going to help us in the emergency department manage our patients. So the first principle is pretty easy, that appropriate access is paramount. It's something that we do all the time. We should be very, very comfortable with. So a couple things are going to be basic, but I'm going to go over some actual numbers. So when we talk about access, we're very comfortable with peripheral access, cortices, which I like to think of as the McDonald's straw, and central lines. But for resuscitation lines, central lines are no good. If you use all 3 ports, it's basically the same as one 18-gauge IV. When we talk about peripheral lines, we know that the bigger the gauge, the faster the speed, but let's go through some of those numbers. So the general rule of thumb is that when you size up, your access is going to be 1.5 to 2 times faster. So if I have an 18 instead of a 20, I'm going to be twice as fast. 16 is twice as fast as 18. And a 6 French cordis, or a smaller cordis, is going to be similar to a 16-gauge IV. The big one is the 8.5 cordis. So with gravity, 100 mLs an hour for the 16 versus 200 for the 8 French cordis, which means we get in our liter of hopefully blood products in 10 and 5 minutes respectively. But by pressure, if we put that through the level 1 and optimal pressure, we're basically going to cut that time in half, where we're down to 2 minutes and 1 minute. So the take home is that if I'm using the right pressure, I'm using that level 1 infuser, I can go up to 5 times faster. And in general, 216 gauge is a great way to start trauma resuscitation, because you're going to be being able to deliver blood products in a liter in a minute in optimal conditions. My first access pearl is that your access should not have a traumatic injury intersect where your access is and the heart. So this is kind of obvious, but penetrating trauma to the abdomen, we don't want to put anything in the groin. If you have a jacked up pelvis, probably not a good time to put a femoral line in either. Access pearl 2 is that if a chest tube is being placed and you're having trouble with peripheral access, it's basically a free shot at putting that McDonald's straw in that subclavian, because the dreaded complication of a pneumothorax is off the table. So if you're doing a finger thoracostomy or a chest tube and you're having access trouble, I want a light bulb to go off and say, Caputo told me this is probably a great time to put a cordis in and beat everyone to the punch. When we talk about IV access, there's a couple of things. One is we want our best people getting access. Sometimes that's nursing staff, sometimes it's a resident. And to me, there's a right way of doing it and a wrong way. So the wrong way of doing it is you're in a busy trauma stretcher, the patient comes in, you throw everything on the stretcher, everyone's trying to do a primary and secondary survey, they get the line in, the tubes fall on the floor, or they're like, I need a blue top, somebody run, get me a blue top. Meanwhile, you don't probably need blood work to begin with for these patients. And it's just a nightmare. The right way, and the way I do it, is beforehand I have a table set up, sterile, I have everything I need right in front of me, and I'm going to extend the arm out. And what that does is it has everything right there, but it's also going to open your chest and your abdomen for someone who needs to either examine the patient or do a fast exam. So use the table. Principle 2 is to give products that optimize hemostasis. So this was looked at in the literature, and there was recombinant factor 7 or activated factor 7, which doesn't have great literature, but the main thing I wanted to talk about was TXA. TXA is widely studied. We have these forest plots, and they're all from the same paper, which is from the Trauma East Guidelines, the Canon paper, which are basically going to look at this. So TXA probably has the literature that's the worst because it's mainly the CRASH 2 trial, and that's not necessarily the patients we're getting here in the city in Brooklyn for resuscitation. But what's found is that if you give TXA early, there may be a mortality benefit. And we have to see how that translates into our population here. My pro for TXA is that the TXA dose is the same as your Ancef dose. So in residency, it's been ingrained in my head that if I needed antibiotics for trauma, I was giving Ancef. It was Ancef tetanus, trauma, Ancef tetanus. So now I could put TXA in that same category and know that it's the same dose. It's 1 gram over 10 minutes to start. And it's best to give within 3 hours of an injury. And the way I think about this is if the person made it 3 hours from a traumatic injury and they're still alive, then TXA is probably not going to help them get better because they're probably not going to bleed to death. But if you could get it to them early, get it to them, this is absolutely a good topic to bring up with your trauma team so you're on the same page whether or not you want to give TXA because they're going to be the ones taking the patient to the OR and continuing the TXA if needed. Principle 3 is to minimize crystalloid infusion. So normal saline is the fluid of choice for trauma resuscitation just because we could transfuse it with blood products, but it has a lot of qualities that make it an enemy in trauma. It's a very acidotic fluid that if you don't put in the warmer, it's going to be cold, it's going to dilute your clotting factors, so normal saline is the enemy. I asked a lot of residents in practice what they think the pH of normal saline is, and almost everyone gets it wrong, and almost everyone is off by at least 1 pH point. It's actually a pH of 5.5, and has a strong ion difference of 0, which means that with continued infusion, you're going to be very acidotic, something that we do not want in our trauma patients. Principle 4 is to control hemorrhage. So we're talking about these large scalp plaques that can bleed, especially if you're on anticoagulation. We're talking about arterial hemorrhaging from the extremities, and we're also going to talk about internal bleeding from pelvic fractures. So one trick in the resus to control hemorrhage while you're waiting for more definitive care is to put a quick whip stitch in these scalp plaques so they don't hemorrhage out while they're in CAT scan looking for more internal injury. Put a whip stitch in with a 0 or a 2. Temporary closes, control the bleeding, and then you could get definitive care afterwards. For your bleeding extremities, the key term that I want you guys to know is proximal control. So we have up to 2 hours without any significant sequelae when we get proximal control until we could get more definitive care. On Staten Island, we have these fancy compression devices. In residency, I did the county way, which was just a portable blood pressure cuff or a blood pressure cuff that I clamped off, but get control, stop the bleeding. When we talk about pelvic fractures, we want to use pelvic winders, so whether it's a T-pod device or whether we're using just sheets to manage the pelvis, right? In pelvic fractures, the leading cause of death in trauma is hemorrhage. You're going to have hemorrhage in 75% of these fractures. 10 to 15% of those injuries are going to be arterial bleeding. So we need to work quickly. We need to identify these fractures and do what we can to minimize the bleeding from these fractures. And this has to do with pelvic winding. So where we want a pelvic winder is going to be at the level of the greater trochanter. Because when you put the pressure in that way, it's going to close your pubis. So a general rule of thumb is that if your junk is easily exposed and has to be boxed out, you're probably a little bit too high. So the picture on your right is probably a little bit too high and can come down a little bit. So this is just an illustration about closing the book. So open book fracture, we're going to put a binder on and we're going to close the pelvis together because that's going to help manage the internal bleeding, especially if it's venous, which most of the time they are. Principle 5 is to avoid and reverse hypothermia and acidosis. Excuse me. So the death triad in trauma is coagulopathy, acidosis, and hypothermia. So what can we do in the emergency department to avoid these things? So a couple of tricks. One is to use the level 1 infuser in the warmer. So make sure the blood products you're giving are warm. If you have to give fluids, make sure they're warm. But we want to avoid normal saline as much as possible. If you have to give it to kind of prime the line or flush the line, fine. Other than that, to a minimum. And then right away, as soon as possible, and we have everything under control, is to use the blanket warmers. Right? So we want to avoid coagulopathy, acidosis, and hypothermia, and the other principles that I'm going to talk about help to do this as well. My transfusion pearl for the level 1 is to actually assign someone to do the level 1. So sometimes this has to be a really experienced person because they're in charge of continuing the lifeline for the patient for this level 1 transfuser. You also want to have someone who's very fast to run and get the blood, because a lot of hospitals I'm in, for some reason, the trauma bay and blood bank are far away, and you have to really sprint to get there and get back. So make sure there's someone in charge of doing the level 1 to say what products are going in and how fast, and test it pre-arrival. You don't want to find out when the patient's there that that there's air in the line and there's an error and it's just beeping and not going, and you have to take it off the fluid warmer. Principle 6 is to use a massive transfusion protocol with the correct ratio. So you actually probably only need one experience with the blood bank to know that when you had a problem getting blood products released, that massive transfusion protocols are basically the best thing since sliced bread. You get a bucket of blood with blood products and you're able to run, and sometimes you don't even need to sign anything, just go and get it versus having to do a million signatures and tell a kidney just get some blood products. So the literature does support this, that all the papers that were looked at in this meta-analysis show that it favors massive transfusion, and that makes sense. But what you may not know is the correct ratio. So we want to know the right ratio of products that we want to give to our patients, because whole blood is going to be red blood cells, but it's also going to be plasma, so FFP, and also platelets. So what's the correct ratio, and how am I going to give this to my trauma patient? This was looked at, and basically a low ratio here is if there's a lot of blood to compared to other products. And most of the time that's 1 unit of FFP, 1 unit of platelets. Low ratio is 2 units of blood are in that area. High ratio is as close to 1 to 1 to 1 as possible. 1 unit of blood, 1 unit of FFP, and 1 unit of platelets. So there's a mortality benefit to giving this high ratio. So just because your trauma patient's bleeding, you don't just replace blood, pre-RBCs. You want to get whole blood, which is going to include, platelets and FFP. So give them as close to 1-to-1 ratio as possible. So give that high ratio. And the last principle is to get to appropriate definitive care. So our trauma team is in the trauma bay. We've become experts at knowing who has to go to the OR, and great, this person's going to the OR, take him. But the other player in this game is interventional radiology, because there are some pelvic bleeds that are hard for trauma to get to, and IR may be better equipped to minimally invasively stop any arterial bleeding. So I have a low threshold for getting a CTA for pelvic fractures, and I'm looking for arterial bleeds and letting IR know early that they may be needed. So not only pelvic fractures, but there's papers that IR can get these intercostal bleeds, because most of the intercostal bleeds in the hospital are actually iatrogenic, and IR can go in there and basically stop the bleeding versus open thoracotomy to stop bleeding. So in summary, 7 principles of damage control resuscitation we spoke about. IV access, so size matters, use for level 1. 2 16 gauges are a great start. Have the conversation with trauma about giving TXA. If you give it early, it's 1 gram, same as your Ancef dose. Minimize your crystalloid infusion. Normal saline is the enemy. Control your hemorrhage, whether it's a whip stitch, closing the pelvis. Avoid hypothermia, so warm your patient, use the warmer. massive transfusion protocol, use it with a 1:1:1 ratio, and get to definitive care, whether that's trauma or IR. If it's IR, get the right study and get them involved early. Thank you guys very much.